the thing that struck me most when my husband passed is I had all of this education and knowledge and all this experience watching other people and helping guide them through this process, but it's so different. I felt like a novice again. And I would hear myself saying things to families that I probably wouldn't say anymore, having gone through it. No one really pays attention or prepares a family, not to mention a bed above all things. It says a lot when, as a married person, you're no longer sleeping in the same bed.
Welcome to In Good Company, Elder Care in Your Backyard.
Dr. Debra Parker Oliver is the Ira Codner MD Endowed Chair in Supportive Care Research at Washington University in St. Louis. A former hospice founder and director, she is a nationally recognized researcher with over 250 peer-reviewed publications focused on hospice care, team collaboration, and caregiver health, and is the author of Legacies from the Living Room, A Love-Grief Equation. Dr. Oliver, welcome to our show.
Thank you so much.
Yeah, we're so glad you're with us. So we got to see you in the Soft Surrender movie, the one by Randy Bacon that just released in November. Got to see you at the premiere. You did an amazing job with the Q&A there. As you were going through and answering some of those questions, I could tell that you have so much vast experience in this field. And the first thing, and I didn't stand up and ask a question, but the first thing I thought of is like, you must know like an amazing story around this. Do you have a story you could share with us?
Fortunately or unfortunately, I'm not sure which. I've actually lived this now 3 times personally.
Wow.
I took care of my husband 10 years ago, who died of cancer, was a hospice and palliative care patient. Then in 2024, my mother passed in a hospice house in St. Louis of Lewy body dementia. And then December 2nd, my father passed here in Kansas City in a hospice house with the congestive heart failure. So I understand it as a practitioner because I started a hospice and I was a social worker in a hospice. Then I've done research for 30 years in hospice. And now I've done it 3 times and sat vigil with 3 of the most important people in my world. So yeah, it's pretty encompassing in my life, for sure.
Yeah. So going through that, what part of that do you bring to your education?
Well, it's one thing to be objective and see families go through it. It's something else to read about it or to see it in a movie. And then it's something, yet again, to feel it in your soul. And the thing that struck me most when my husband passed is I had all of this education and knowledge and all this experience watching other people and helping guide them through this process. But it's so different. I felt like a novice again. And I would hear myself saying things to families that I probably wouldn't say anymore, having gone through it. Because things are a bigger deal than you think when you actually feel that. Like, for instance, when they moved the hospital bed into the house, which is a common occurrence. And I remember people saying, oh, my house is just all messed up and it looks terrible and people are coming in. And I say, oh, don't worry about it. Don't worry about it. No, that really is a thing. I mean, your home is your castle. It's your sacred space. And then you bring in this foreign equipment that makes it look like a hospital. And it takes away some of the comfort of the environment. And we don't attend to that. No one really pays attention or prepares a family, not to mention a bed above all things. It says a lot when, as a married person, you're no longer sleeping in the same bed.
Yeah.
And I think we don't pay enough attention to those kinds of things. So you experience it in a different way, that's for sure.
Yeah. Oh, are there other examples of that?
Even giving the medicine, you think as a professional, you teach somebody how to give the medicine, the nurses come in, they set it all up and kind of walk away and like, okay. And then the doctor will order, no, you need to cut back on this particular pill. And you're sitting there and you're looking at a box that's got 15 white little pills in them. Which one do you take out?
Mm-hmm.
Or which one do you put back in? Now you've got 16. Which one is which?
Mm-hmm.
One of the tricks I did, people writing I'm absolutely crazy, but I would put initials on those pills, actually write on the pill an initial in order for me to know which one was which.
Mm-hmm.
It's the only way. And I actually had a physician say, well, they have little numbers on them that you could refer to. And I'm like, are you kidding? I'm 55 years old. I can't see those little tiny numbers. My stepmother taking care of my dad. She's 89. She's going to see these. You got to get a microscope to see that. No. I can see my black T that I put on there or my black M. Much easier.
Yeah.
And as a professional, you don't think that much about it.
Yeah. Yeah.
But as a family member, whew.
So when you're talking with families and you're preparing them, because I hear this a lot, and we've done a few hospice-focused podcasts, but what are the main things that you kind of, when you say prepare, emotionally and what they're going to see, what are some of the top things that you're warning them about?
My most recent research is actually on this very subject of preparing families, especially for the final 7 days, the vigil, so to speak. I interviewed 50 family members who had been through that vigil experience and asking them, what could we have done better? What didn't work well? What are your memories? And overwhelming, the first thing was the sounds and the sights of dying. It does have a sight and it does have a sound. And the sounds can be very scary if you don't know what they were. Mm-hmm. And I remember for years and years talking to families about this and talking about the death rattle and explaining to them and explaining, that it's terminal secretions. It sounds like somebody's sucking through a straw. They're not uncomfortable. I did not know about agonal breathing. And my husband had agonal breathing, which is a moaning sound, right? It sounds like pain. It's not pain, but it sounds like pain. Well, the number of people that had that very experience and had not been prepared as to what that is. And it's a sound that will live with you for quite a while after. Especially if you did what I did, and that is I pledged to my husband that above all else, he would have no pain. Mm-hmm. Now, during the time, the nurses would tell me that, but had I known that in advance, it would have been really helpful. And I've been around hospice nurses for 20 years. Nobody talks about it. I think nobody talks about it because it's so awful, quite frankly. Yeah. We don't even know. They don't record it. We don't have a clue in the literature how often this happens. We don't know. Yeah. And yet we know it happens. About 30% of my people interviewed talk about it. Or then there's that chain stoke breathing. That's a whole other kind of breathing. Yeah. So we've done focus things about that. So people stop breathing and then they start again. Mm-hmm. And so that can be very scary and has a whole different sound. I think everybody kind of expects it to not be pretty. And so the sights are a little less unexpected. But when somebody starts turning blue, when the modeling starts, if they're not prepared appropriately and they haven't been told about that, or if they're just told, they're going to get a little discolored and then they see it, that's alarming. When my father was dying this December is the first opportunity my family has had, my stepmother, my brothers, to know what I do. Nobody really wants to know when you're in death and dying what you do, right? Yeah. We don't want to talk about that. Debbie just does that stuff over there. So I would tell them, what to expect and why it was happening and how we know. And they were just amazed. They go, how do you know all this? I'm like, well, this is what I do. This is sadly not my first rodeo. This is my third rodeo. And so it is specialized knowledge, but nobody wants to know until the timing is right.
Yeah.
And so that's the other thing we have to learn as we try to better educate families is how do you do it? When do you do it? And when are they ready to hear it? Some people never want to know. That's a very individual thing. And we have to pay close attention to that because it's actually the best intervention during the vigil period that we can do is to educate families on their own terms.
Right.
I'm a researcher. I want to know everything. And I'm a teacher. And so my tendency is to tell you everything. But I got a brother who wants to know nothing. And I'm going to mess him up if I try to force pictures in his head that he didn't want to see.
Right.
And so you have to be gentle about that and know yet that my mom wanted to know everything she needed. She wanted to understand what does this mean? And when is it going to be? And how do you know when it's going to happen? So it all is, it's a very individual thing.
In your research, have you noticed that there's a difference in how people take the information if they've been exposed to it already?
Most people have not been exposed to very much. We had people who had been through it before with somebody else and then now going through it again. And not every situation's the same. And so they would refer back to when my grandma died and I was with her, then I had this happen. So luckily when it happened, I knew what was happening. So that's a positive. But on the other hand, you'd have people say, well, they had this experience and then this didn't happen. And I kept waiting for it to happen. And because it's also individualized, and when we are good about teaching, preparing people, I'm not so sure we're good about reteaching them.
Right.
Or teaching them that what you learned before might not happen again this time. It might be different.
Right.
And the setting is different. If you're in an inpatient hospice facility, which I was lucky enough to have my parents both at one, that's a different experience than when you're home alone and you're dealing with this.
In what way?
When you're home alone, you're alone. I mean, you got to pick up the phone and call somebody. Or I had my daughters with me, but they didn't know what to expect. And so he dies. How do you know he's gone? You can't just go out and ask the nurse. So you call and then the hospital, and you don't want to call too soon because what if it's not the case? And I don't know how to take a pulse. I'm a social worker by clinical training, so I'm more like what a normal regular person would be. So you do the best you can. And the nurses said, well, listen, well, look, because he had some noisy breathing, when the breathing stopped, that was kind of a good clue. But I wasn't real confident about that. So you pick up the phone, you call the hospice nurse, and they kind of walk you through and they're on their way, but it's going to take a little bit of time. That's different than walking out. I walked out to the desk when my dad died and I said, I got quiet and I couldn't feel any respirations when I put my hand up to his nose. I think maybe it's time. And they're able to come in, and it was a nice, quiet, and eventful thing. Where at home, you're trying hard not to panic.
Yeah. Yeah. So I remember, and I had a little bit of a unique situation, but my father was in a hospital setting, and they, long story short, we didn't end up on hospice. They put us on their palliative in the ICU. He went through all of those breathing changes that you had described. I've owned a hospice for 15 years, like I'm just similar to what you said, I've been in the business for a long time, but until you go through it yourself, it's like you'd heard the terms before, but when you see it for yourself, it is a bit shocking. And it was for me. And, those last breaths were extremely far apart,
Yeah.
way longer than you would ever expect anyone to be able to go between breaths. And, I was with him the whole time, and you're just sitting there going, is this it? Was that his last breath? And then he would take another breath,
And then you go, oh, and now what? I mean, you're just sitting there staring, watching. At least the first time I've learned now not to do that.
Yeah.
You can cope better if you don't do that. But the natural instinct is to sit and just watch.
Yeah. He went through all the different types of breathing, and he went through the moaning breathing as well.
It's the worst.
And, I was holding his hand thinking, well, maybe he'll squeeze my hand or something if he needs something. And, we're trying to swab his mouth out a little bit and just, trying to keep him as comfortable as possible. And that was one of those things where, having the information, having, a hospice person to kind of lean on, that, it really makes a huge difference. And unfortunately, in the hospital setting, although I think they deal with death and dying on a regular basis, I think the hospice clinicians they just know like when to jump in and when to say what. And I've gotten a great opportunity to talk with some of our staff, and it's just they've just gone through it a lot with some of these families. And tell me about your research.
So we work on developing interventions to try to help ease the caregiving burden and make it better. We have all the research in the world that tells us that caregiving does shorten your life. And people who do caregiving end up with chronic diseases and health issues that literally can take years to recover from, because it's stressful and your health goes on hold while all your focus is on your family. For instance, with my parents, with my dad, in 26 weeks, we had 13 hospitalizations and 40 different medical appointments. Well, you think I got time to go do my annual appointments? Not hardly, not in the middle of all of that. So you put off your own health. With my husband, that happened for 4 years. And so then by the time I was able to attend to myself, I had some of my own health issues that took me like 4 years to resolve. So what can we do to help caregivers learn how to take better care of themselves and to ease the burden and to prepare them, not just for the final week, but for the tasks at hand? Nobody teaches us how to do this stuff. Yeah. It's like parenting, nobody teaches you how to do that. Mm-hmm. And you just kind of learn. Well, dying is even worse because you don't have a bunch of mentors to help you do it. When you parent, everybody's willing to tell you how to do that. But most people haven't been through dying, and so they don't really know. Yeah. And how to support one another. It's a very lonely experience. You think you're probably the only person in the whole world going this crazy and doing all of this. So we have done a lot of work with telemedicine and the use of online support groups and online kinds of technology in order to try to ease this process. Teaching caregivers how to ask for help. We are taught in our country, don't ask for help, right? Be strong, independent. You can do it yourself. You're wonderful. You're great. Or when people offer to help you, and lots of people will, how do you say yes to that and feel okay about it? Mm-hmm. And even teaching people around us how to offer so that I can say yes. It makes it easy, or that I just get the help and I don't have to. The best people in the world are the ones that brought stuff to my door and they sat it on my door, and they left and they messaged and said, I just dropped a lunch off at your door. I hope you enjoy it. I mean, that was wonderful. And they just do things with come and cut your grass. They don't say, can I come cut your grass? They just come and they just do it. And it's just done. And you can just be appreciative and not feel bad.
Yeah.
Learning how to ask for and accept help is really big. And how to be ready for those crises that come, because they happen. Especially they happen before you get to the hospice stage, and you're always in the hospital because of dehydration or one thing or vomiting or one thing or another, right? Keep a bag packed because you're going to need it. And what are you going to need in that bag that you pack? Because you're going to be stuck at the hospital for hours, days, or whatever. So take some things in there that help you take care of you. So our interventions test all of those kinds of things to see, are caregivers better as a result of doing these things? Does it make a difference? And we really try to target on depression and anxiety, which are two very commonly known problems that caregivers have, and nobody assesses for that. Nobody in the medical system assesses for that. Not even the hospice, a lot of times. And where do you put that in a chart? Because the charts are about the patient. Only in hospice are the charts about the patient and the family. But the doctors, they don't, even in palliative care. I've been through this 3 times, 3 different hospice programs, 3 different palliative care programs, and nobody has one time assessed my depression or my anxiety. Not once. And I'm the person that's like out there telling everybody to do it, and nobody's doing it. So we got a long way to go. We're going to treat the patient and the family, then we got to do some assessment of the family.
Right.
But if you're going to do the assessment, you also got to be able to do the treatment, which we don't want to just know you're depressed. That means we got to do something about it. And so what do? So our team is trying to create a toolbox of different interventions that you could do with the family, be it the social worker, the chaplain, the nurse, whomever, that will make a difference and that have shown that they decrease. We have a problem-solving approach that we use where we teach families how to systematically go through problem solving, and it makes a difference. Those who have been taught those skills have lower anxiety than those who don't have those skills. And that's in a sample of like 500 using randomized control trials. So those are the things that we've been able to do. And most recently now we're in the process of looking at how do we compare those different interventions, who benefits most from an online support group versus the problem-solving intervention. And how do we know that? And how can clinicians know which tool out of the toolbox to grab for which people? And we've had so few tools, let alone a toolbox, that we haven't known that.
So when you look at the caregiver, and I love the direction that you're going with your research, because it's actually going to be a big focus for our podcast for this year, is looking at the caregiver and all of the medical conditions that tend to pop up, even in that age group, that demographic. So I'm assuming there's some research out there indicating that caregiving, for lack of a better way of putting it, could be bad for your health.
Oh, is bad for your health. Yeah. Like almost 100% of the time.
And so can you tell us a little bit about what findings you found when you started looking into this? So
we know, there's not even any debate any longer on that issue. We know caregivers are more depressed than those that don't caregive. We know they have higher anxiety. As a result, they also have more chronic diseases, and those vary in range, and they have shorter lifespan. It takes time off of your life. I'm going to use my 89-year-old stepmother as an example, who's been caring for my father for a year and a half. until he passed. And first, she's 89 years old. So she's got her own set of issues, right? But she also has this value that a wife takes care of a husband no matter what, without complaint. It's what you do. Now, she had already been dropping weight, and now she's trying to take care of dad and manage him and watch for, at that point, he was having strokes. And then she came down here where I could be more help. And so we were looking for strokes and congestive heart failure and renal failure. We're adjusting medicines, and he's on 30 pills per day. And an 89-year-old woman is going to try to manage 30 pills per day that change frequently depending upon his blood pressure, which she has to take every day. He's also got vascular dementia and gets lost, even when he's in the bathroom. So he's hollering for her in the middle of the night. So now she's not getting sleep. So now she starts to get confused on top of everything else. Guess what? She also starts losing more weight. It's a circular thing. One of the joys of the hospice philosophy is that we've always talked about, Cicely Saunders talked about, it's the patient and the family as the unit of care. So we need a care plan for both the patient and the family. How's she going to sleep? How's she going to manage those? She's got to pick up her phone and call somebody to help. That's how. But she's got to get over the fact that she's not a good wife if she doesn't do that.
Oh, yeah. That's
all psychosocial stuff.
Yeah. Yeah. Oh boy. Yeah. And so much of what the hospice system is designed for, it's designed for families, but most of it is designed for the patient as well. And so I can see where that could get lost in the shuffle.
Even all of our certification and licensing requirements are around patients. Yes, you must see the family. Yes, you must do an assessment, but there's nothing about what you got to assess.
Right.
Or what you got to do based on that assessment. Yes, you got to do bereavement, but what does that mean? We all know that it's a great requirement, but it also means a whole lot of different things depending on which hospice program you're in.
Yeah.
And so we got to tighten that stuff up because just like the healthcare system pretty much people are pretty much invisible. I was giving a speech at a church group one time, and this lovely little lady comes trudging up afterwards, and she says, "You are so right." She goes, "I was just invisible. They just didn't even see me. They would ask him how he was, and he would make up this story, and nobody said, how is he really?" Because he didn't want to be a bad patient. So he didn't talk about the fact he was up puking all night long. He said he was fine. I knew better. But nobody asks me.
Yikes.
And so I tell physicians, I said, there are two things you could do that would really help. Two questions you need to ask. That's all. First, you turn to the caregiver and say, what do you think about how they are? And the second is you say, how are you doing? Just asking the question.
Right.
At least gives them an idea that you see them and you care. And then asking the question, how do you think? Or when you prescribe a treatment, do you think this will work? Because you're the one that's going to implement it.
Yeah.
And nobody asks.
Oh boy. Well, you just unboxed a lot of issues that are even outside of, palliative care and hospice. Spencer, what do you have?
Yeah, I was going to ask, how did being both a researcher and a family caregiver change you and your perspective?
I've gone back and forth wondering if it was an advantage or disadvantage. The advantage I had is that I have a network of people that I can pick up the phone and call and say, doctor told me this, what do you think? And that, especially before hospice or palliative care, and that made a big difference. The disadvantage is I know what's coming. And so I can be proactive and sometimes more proactive than the healthcare team. And that's very frustrating. And I have very high expectations for what palliative care and hospice can be. And they're not always meeting that expectation. I've been amazed. I started this when there was no palliative care, when it was hospice. You had hospice or nothing. And then palliative care came into being because we had people that didn't want to talk about dying yet or admit that they're dying and still had needs. And so we had palliative care. But palliative care isn't regulated. So what your palliative care program is and what somebody else's palliative care program is are going to be completely different. They kind of have the same philosophy, but how that manifests itself. And they're confined too often to a place, to a hospital, for instance, is a great example, or to a clinic. So my dad was on palliative care in Hospital A. He has signs that exhibit like a stroke, and because of that, he's taken to Hospital System B, because by law, they got to take him to the closest place. So I'm sitting in the ER with him in Hospital B, and they are doing crazy things, not really focused on palliative care. The doctor's more concerned about his sodium level than he is about the fact that I think that he actually maybe purposely tried to do something to himself.
Wow.
So I pick up the phone and I call, and you have no case manager in your life outside of yourself. So I pick up the phone, I call palliative care team A, and I say, I need some help. Am I crazy? Should I be concerned about this? What do you suggest we do? Well, we can't help you because you're in Hospital B. But if you'll get a palliative care referral for Hospital B, then they can call us and we can work with palliative care team B. Okay, emergency room doctor, I need a palliative care referral for your hospital. Why? Because my dad's got congestive heart failure. It's a serious illness. He meets the criteria. We already belong to A. I need to talk to somebody with B. No, I don't think so. I'm like, no, this really isn't up for debate. And so I have to advocate. Now I'm tired, exhausted, and I happen to know a few things. Most 80-year-old women are not going to do this. But I insist. Palliative care team B calls me and says, you're in the ER and you need palliative care. Do you need a hospice referral? No, that's not what I need from you. I am needing a psych referral for my dad. And palliative care team A suggested that I talk to you. Maybe you could call and talk to palliative care team A, and together you could help me. No, we really don't do that because you're just in the emergency room.
Oh my goodness.
And I said, do you know who I am? And I hate doing that. Because I'm a social worker and I'm telling you my dad needs a psych consult. And I'm a professor and I do research. Oh, okay. Well, then if you say it's a problem, it's a problem. Really? We messed up. Right? Everybody in that messed up. And that's, I noticed that and I knew that because of my professional side. I knew it needs to be better.
Yeah.
Go into hospice. My dad was put in an assisted living facility. Okay. I know, everybody knows, if you're going to go into a facility, you're better off with hospice than without. You're going to get better care. So the day he's admitted, I want hospice A. I know the people. I know what they're about. They meet what I like. So I call hospice A and I say, and I'd actually been talking to them all along because congestive heart failure, I know that it's hard to meet the criteria, but it is time. And I know it's time. I talk to the intake coordinator. She goes, you need to call and get a referral from your doctor before we can come out and do an assessment. I need to call? Do you work with palliative care team A? Oh yeah, we know them. I said, but you want me to call? Yeah, you need to call. We can't do that. you kidding me? 5 calls later. That was a 5-day delay.
Oh my goodness.
By the time that we went through the palliative care team who communicated with the physician, because we couldn't get an attending physician. That takes 9 months, and Dad didn't have 9 months. So 5 days, and he only had hospice 5 days because those 5 days were taken up. And that was 5 days of unmanaged pain and problems that I was having to take care of. Ended up being admitted on Thanksgiving Day because we lost all those days before. Because you can't just pick up the call and call. You got to go through a portal and give a message. And then they had to get that message to the lead palliative care person, who then had to get a hold of the cardiologist, who had to decide if he wanted to be the primary care doctor or was there somebody else, because we didn't have a primary care doctor. You see how crazy that is?
Mm-hmm.
And so now you put the caregiver who's exhausted, dealing with all of these things, in charge. Why in the world an intake coordinator couldn't have picked up the phone and called their buddy over at palliative care team A and said, hey, does this make sense? Because they'd already been talking to me. They knew what was going on. And or just call the doctor directly. But no, it became my problem. So it's thrown back. There's actually a research term for that. A researcher in Malaysia did a study, and they call that interactional suffering. The suffering that occurs as you interact with the healthcare system with the team that's designed to eliminate suffering. And every time a caregiver or a patient interacts with the healthcare system, what you're doing is you got to put on this suit of armor because you know it's going to be a hassle.
Mm-hmm.
I've just always thought that once hospice came in, that didn't happen anymore. That should go away.
I can literally feel the people watching this in the future nodding their heads at almost everything you're saying, because somebody, even if they're not dealing with a hospice or palliative situation, has dealt with some sort of frustration where they need help. They're literally saying, help me. And sometimes they run into people who say, that's not my job.
Right.
And it totally is, and that is, oh, I feel for you on that.
Every interaction we had with the healthcare system, the question would come up, who's your primary care doc? We couldn't get one.
Yeah.
That's a great question. And they said, well, you need to get one. By golly, we do. This is in April. We have an appointment in January, which of course we never got to meet. You never got to do, because there's a waiting list.
Yeah.
So it's great to say that, but if there's no one, so what you have, because you don't have enough primary, and I knew there's a shortage of primary care physicians. I had no idea how bad it was.
Mm.
And what an impact it has, because nobody else is going to manage your whole care. You got cardiologists, they're going to look at cardiologists. You got a renal guy, everybody's going to look at their piece of you and require you to make all these visits to all these different, but nobody's looking at the whole picture. And that's not their job.
Yeah, some of the best, most amazing hospitals, Cleveland Clinic, Mayo Clinic, all have a kind of I don't want to say committee, but board, that they have a group of physicians that are working on a case by case. They bring it together and they're all kind of pushing each other to be better. And why we can't somehow make that work in the rest of the healthcare system better, I think it's something we should look at for sure.
And the primary care docs, as critical as they are to that whole thing, are the least paid. And we wonder why nobody wants to go into primary care.
Yeah.
I mean.
Yeah.
Okay.
I know the good news on the hospice side of things can be, we run into this every once in a while where somebody doesn't have a primary in our hospice. We have several hospice physicians in our company, and they'll take that patient on, and they do an amazing job because they know hospice really well, and our nurses are great at communicating symptom management to them. And, it's, our obligation, I don't know if a lot of people know this, but the obligation is that if you have somebody on hospice and they have an urgent need, that agency is supposed to have a clinician in your home within an hour. And that's here in Missouri.
Yeah.
But I don't know that everybody knows that, but even further than that is that if there's some hang up and we're not getting orders quick enough, we're not getting responses quick enough, we can move a family to our hospice physician, and that hospice physician and they're amazing. Like, it's one of the criteria for working for us is that we have to have very fast turnaround time, because you have sometimes very short period of time to deal with some of these symptoms, and especially if somebody's in pain, like, we got to go now.
Right. Case management and the medical direction are really one of the number one reasons why people should sign up, because you have one call.
Yeah.
And you make that call and it's fixed. And the nurse can make a call and call directly to a doctor who will answer the phone.
Yeah.
Themselves, not
Yes.
go through 14 gatekeepers to get you there.
Yes.
And nowhere else in the healthcare system does that happen. But why do you have to be dying? Literally dying
Yes.
before you get that care.
100% agree.
I thought we got that with palliative care. That's where I was also, that's a learning I had. So we go to palliative care, and what kind of things do you need? And I'm like, well, I need a case manager because I'm the case manager. I'm not qualified to be the case manager. Don't like managing all of these people. I want to be a daughter.
Yeah. Yeah. You need to be.
Guess what? No, you're still the case until you get to hospice. I think somebody's or nobody is the case manager. And that's when we have even more troubles and people end up in emergency rooms and all of those kinds of things so many times. But that's one of and the call nurse, because these problems happen at 2:00 in the morning, not at 10:00 in the morning.
Yeah.
And you need that help now. Not next week, which is why you don't want to wait 5 days to admit somebody.
I've witnessed and experienced healthcare my entire career, and there's just so much, people are just baffled, and they're told all kinds of things. And one of the running jokes in as a provider in the Medicare space is if you call Medicare 10 times, you will get 10 different answers, 100%. And you'll find that throughout healthcare in general. Like, you think you're going to get the same answer that everybody else is going to give you, but you won't. And sometimes they'll tell you things that are absolutely not true.
Right.
And they believe it. Like, they're not trying to lie to you. They really believe it's not their job. And it's like, no, this is your job. And you're supposed to take care of this, like, right now. And you're supposed to communicate with other clinicians and not lean it all on the family. And I've heard other people say, well, let's, just have the family take care of it because of, I don't know, legal issues or something like that. It's just all BS. I'm sorry. Yeah. It just is.
And everything, all the big saying, stuff rolls downhill, and downhill at the bottom, there's the family. And then we wonder why they're exhausted. They're not sleeping. They're stressed. They're depressed, and they're unable to take care of their loved one, and why they end up then going to the emergency room. That's not okay. The comfort packs are wonderful. Put that into an assisted living environment, right? And they're great. But we also know, everybody in the business knows, if you're in a long-term care facility and something is ordered PRN, that equals never. Because it doesn't happen.
Yeah.
And so here's Debbie. We got pain. I know we got pain. I know we got a comfort pack. Now, how do I get them to give it to him?
Yeah.
So I go and I say, nurse got the cart right out there. And I say, okay, he's refusing to swallow his medicine. I know we got liquid morphine. I know you got an order there. It's time to give it. Well, I don't know. I said, yep, we're going to put in a little bit of water. So he doesn't know it because he's refusing his medicine, and then he's going to be comfortable and everything will be fine. I don't know. I said, tell me what is against the rules that you can't do that. Well, I'm just not comfortable. I said, no, he's the one that's uncomfortable. You've got an order. That means you got to do it. If you think he's uncomfortable, now tell me he's not uncomfortable. He's moaning. So why do you think he's not? Oh, no, he's in pain. Then it's an order. You have to do it. Well, we had to call 3 people. It was nice the medicine was there, but it's not at home. And this is what the difference is. At home, I give the medicine. It's no problem. No question.
Interactional suffering. Suffering.
Is it not a great term?
I need to get a t-shirt that says that.
Yes.
Interactional suffering. Let's put an end to interactional suffering.
And, and the people have the best intention.
They do.
They truly do. All the healthcare team, they're all there for the right reasons. They may even have the right skills, but they don't get the other side until you've been on the other side and you've been up for 3 nights in a row, constantly worrying.
Yeah.
You don't get it. And I was taking care of 2 people, because if you've got an 80-some-year-old caregiver, you got 2 patients. You don't have 1. You've got 2.
Mm-hmm.
And aren't recognizing that.
I'll have to say, I do believe this is organizational and leadership. My daughter, when she was 3, got leukemia, and we were plugged into the St. Jude system. And so we go to Memphis, and you talk about an organized setup that is designed for patients and families. And every piece of that system is impressive. We didn't have any bad experiences at all. And things were super organized. Like, they wouldn't make you wait. They just get your cell phone and they'd text you when it was time to come to your appointment, and you'd literally walk right in. And otherwise you were, in the cafeteria or in the playground, or, there were several places for you to go, or maybe you were back, sleeping back at the, local place that they would put you up for the night. I'm not saying that healthcare system has to go that far, but I'm just saying there are a lot of things that they could make work better. And these teams, they really truly act like a team.
Right.
They know what the other one's done and taught, and they, it's like, oh, let me check and see what time your next appointment is at this other clinician. And, oh, it looks like you're going to be running late. Here, I'll just message them here and they'll get you right in it. And it was like, we didn't have to do anything. It was just organized really well. And they communicated extremely well. And 99% of it is communication. It really is.
It is.
It's,
in the 90s, we had this movement, the service quality movement, right? And the Baldrige Award and healthcare systems got involved in that and tried to create those kind of environments. And that has just gone away. You don't hear about service quality and service excellence too much, but when it works, you see it and you notice it. When we got to hospice, they communicated with one another. The social worker was working on transportation while the nurse was working on taking care of Dad to get him to the place. I did nothing. I was daughter. I got to stand back and watch. But within a hospital setting, forget it. They're not reading their notes. They're not talking to each other. It is total mayhem, and you're the go-between. So what did that cardiologist say? What drugs are, and I love how everybody asks you the same question over and over again, like it's not written down. You're constantly going, I said, you really want me to go over all 30 drugs? Here they are. You really, nope, we got to go over them. I said, I went over them yesterday. So just the same. Nope, got to go all over me. Are you kidding me? Yeah.
Interactional suffering. Oh, you've just given me a new a new phrase to lock in on, because that is exactly what people feel, unfortunately, in the healthcare system. And you said it perfectly. Like, these people have great intentions, and some of them are extremely good at their jobs. It's just the system that they work in is so bifurcated, and it's disjointed. The communication is poor, and so much of it leans on the patient's memory
Right.
God help my family. If you have to have me name my dad was a pharmacist, but I couldn't name half of the drugs that are out
Right.
there. And so if I mispronounce one, God forbid, we're going to have a problem.
And I had a notebook that I wrote everything down because I was stressed. Like half of that notebook was for my mom, half the notebook was for my dad. And if I didn't write it down, then there's no way that I could remember. Who tells you to do something like that? Who gives you that hint? Nobody. You just got to figure it out on your own. And every time you turn around, they're going to ask for this number and this number and this number. And every time they turn around, they're going to want this credit, this insurance card and that insurance card. Doesn't matter if it's the same system. So you might as well have it all there already and just hand it to them every time you go anywhere. So have yourself a packet and hand it to them. And prevent some of that interactional suffering.
Spencer, what else do you have?
Yes. At the top of the show, we mentioned that you're an author. You wrote Legacies from the Living Room, a love grief equation. Tell us about that writing process and what you want readers to take away. That
is the story of my husband's 42 months with stage 4 cancer. From the time we did treatment and diagnosis, and then through some of my grieving experiences. And he had a saying, there's a love grief equation. The more you love, the more you grieve. And if you love a lot, you're going to grieve a lot. And I had purposefully, throughout my career, kind of avoided grief and bereavement. You got to kind of focus somewhere, and that was not where I was going to focus. So this was my really first experience with grief. And part of that, he had written an ebook, and he always said, you're going to write a book someday. I said, no, I do science. I do peer-reviewed literature. I don't. And that was great therapy for me to write that. So it's all from my perspective, how I experienced all of these kinds of things we've been talking about today, as well as processing that happened within our family. We interviewed my family, my kids and his kids, and how did they experience it as grandchildren, as children, and me as wife. So it's kind of the story of our family and how we went through that together. We chose to be very open with the whole experience. Matter of fact, we made YouTube videos, and we were on CBS this morning sharing that philosophy. He was a professor as well, and so education is, and we were in the medical school, so education is kind of what we do. And it's that story. And it was incredibly meaningful to write. It won an Indie Book Award.
Oh, wow.
And it's been kind of the thread throughout my career. It kind of tied it all up. The whole, what do you know, and how does it end up being? It was a lot of fun. And I'd never written, this is my first book. I'd never written a book, only peer-reviewed journal articles.
That's awesome.
That is awesome. That's amazing. So when we just circling back to your research, there are caregivers that are going to be listening to this podcast, and they're going to need some education on what to look out for, because obviously, as we just talked about, it can be bad for your health. What message would you give?
And point folks gladly to a resource due to the generosity of the Hospice Foundation for outreach in Springfield. We have partnered up with them and just recently launched a website and a program. We're calling it the Learning Institute for Global Hospice Training, designed for hospice caregivers specifically. Right now, it contains a series of videos, the breathing stuff that we talked about. How do you get social support? How do you ask for support? Short little videos. We're going to have handouts attached to some of that. We're just now building it out. But it is at www.light/institute.com. and has some really great short resources. And I talk caregiver to caregiver. It's one thing to talk nurse to caregiver. No, this is not an how-to. This is how I experienced it and what I learned, and I think would be helpful to you. There are other videos out there on the internet. I will say mixed. I would give those mixed reviews. Years ago, there were none. When I started in the idea of caregiver education, there were none. But slowly the need is arising and people are actually embracing this. But we're loyal to no one program, no one hospice agency, no one. It's just taking the research and the evidence out there and giving it to people in a level that is understandable and hopefully helpful. And it gives an email where people can give us suggestions. There's also a book on there called Voices, which are words that we've gotten from hospice caregivers about the whole experience of being a caregiver, and put together in a little tiny booklet that is easy to read, and so people don't feel alone. Because I think that's one of the worst things. It's so isolating for however long it is, if it's a day or if it's, some people are on a year, you're home alone. And that's when it gets really scary. And so reaching out, that's the joy that the internet gives us, podcasts like this and other things that bring us together so that above all else, no, you're not alone. And there are people out there that are studying this. There are people out there that are experiencing this. Reach out. They will talk to you. I will respond every time. So will other people. It's the best part about writing the book or publishing something when somebody reads it, then you can help. Because otherwise, how can you reach out if you don't know where to go?
Wonderful. Dr. Oliver, thank you so much.
Thank you.
For the work that you do. I really think not just your research, but the stories you share, your book you wrote. I actually am going to try to track that book down and read it, because I really think the more people understand this part of society, which, as you said, people may not want to know, but we kind of take the notion that the more people face it earlier and understand that it's a part of life, and it's not an ugly part of life. It's actually a beautiful part of life and can be wonderful and bring families together. And
yes.
So many wonderful things can come of it. It's just a lot of suffering goes on around these things, and we want to try to get the word out there so we can help as many people. And you are doing a wonderful job of doing that, and I really want to thank you for that.
Well, thank you. And podcasts like this are great. They're great tools to get that information out. People are going to die, and you can choose to do that in a beautiful way, or you can choose to have conflict. And
Right.
if you're going to ignore it until it becomes a crisis, you're going to have the bad way every time. And
Right.
that open conversations among families, even if it's uncomfortable, even if you're not used to it, having those before you have crisis is going to make your life so much better. And I've seen it so many times, as I know you have too. It's not the Thanksgiving conversation that we all want to have, but it's the one we need to have.
Absolutely. Makes life richer. It does. Thank you again, Dr. Oliver, for being on our show. We really appreciate you.
Thank you, and thanks for doing this.
If you enjoyed today's conversation, make sure to like and subscribe so you never miss an episode.
And we'd love to stay connected. Follow us on YouTube, Facebook, and on Instagram at In Good Company Elder Care Podcast.
You can also find us on X, formerly known as Twitter, at IGC Pod, and on TikTok at IGC Elder Care Podcast.
Thanks for tuning in to In Good Company Elder Care in Your Backyard. I'm John Ray, and I've been joined by my amazing co-host, Spencer Ernst. Special thanks to our executive producer, Alex Wallace, for helping bring this show to life. Until next time, take care, and remember, you are always in good company.